Okay, so without further ado, Dr. Troxler is our presenter today, and you heard me talk a little bit earlier. We're going to be doing a case presentation today. We're going to discuss that case about some motivational interviewing and about a challenging patient situation in which we could use motivational interviewing. So I'll let you take it away.
All right, so I have a case, but I am also going to be heavily relying on Meredith to remind us of the content from the lecture she gave us before. I've got a few things kind of literally pulled from her presentation to kind of give a little bit of structure to the case I'm going to present to you guys. So it will be a case that I'm presenting, but it will be um, based off of, okay, let's see what we're seeing. Based off of Meredith's presentation from last time. I want to do slideshow, yes. Okay. All right, you guys are seeing a beautiful picture of a lovely pair. Are you?
We are.
Okay, excellent.
Yes, we do.
As always, if nothing else, I hope that visually the presentation is pleasing. Because sometimes that matters more to me than anything. So motivational interviewing with the case presentation, that's me. When the situation is not easy, and of course I have no financial disclosures. So the critical components of motivational interviewing of motivation, as we learned from Meredith's presentation last time, willing, able, and ready, our client. Where are they on the spectrum of these things? The degree of discrepancy between what is happening at present and what one values for the future. So what am I experiencing now? How close is that to what I want tomorrow, next week, a year from now? Am I able to make a change if there is a discrepancy there that I want to correct? How confident am I that I'm able to make that change? And even if I do have some confidence in my ability to make that change, and I'm willing, because I see that mismatch in my lived current life and where I want my life to go, am I able to make that change a priority? Am I ready to make that a priority? There might be some things that get in the way of me making that a priority that absolutely have nothing to do with my willingness or my confidence in my ability to make the change. And we'll kind of see some of that with the case that I'm going to present to you guys, because I think we sometimes maybe think of internal things getting in the way of our patient's ability, which is definitely part of it, to make change, sustain change. But sometimes there are external components that impact our ability to engage in the change that we see for ourselves and want. So one of the things that Meredith highlighted for us before was the importance of change talk and not missing that. Having our ears really finely tuned for, we may be talking about something entirely different and we weren't expecting it. It's something we haven't been addressing. Maybe they have a methamphetamine use disorder and they're like, but I really want to decrease my drinking. Or it may be like alcohol, that statement kind of lends itself to alcohol, but it may be like, I really want to decrease my drinking of Mountain Dew. Like there's another change that I want to make. We make it super focused on the one that seems to be the most important to us, but they might have some other area that they want to change and maybe feels more within their grasp. So any change talk, whether it's related to the thing that we think is the most important, and again, aligning agendas, what is our clients should be ours, and paying attention to the change talk and is it matching with where we're putting our focus as well. So don't skip over to it. Don't skip over to it. Don't skip over change talk. Immediately respond or make a note, whether it's jot a note down, make a mental note, some way to kind of work your way back around to some of the change talk that you've heard. And if you respond to it, just like anything, somebody's trying out a new outfit today and they're like, I don't know if I'm pulling this off. And, somebody on the street corner is like, I really like that outfit. That is really cool. You're like, I am doing this again. I'm going to try this again. I'm going to stretch my neck a little bit and try something new. And yeah, I do. I think I can do this. I want to invest more in this change that I've identified for myself. And then just a lovely little mnemonic to kind of help us clue in with that fine tuning around some of the change talk. They're kind of preparing for, thinking about, they have a desire, they express an ability. There are some reasons that they need to do it. Some of those things might be needs that they can see and recognize that a change needs to happen. So preparing for the change, and then I'm making the change. I'm getting into the action stage. So commitment to the change, that activation piece, and then what steps they're taking in the direction to initiate that change. And then the 4 tasks of MI, and I've kind of arranged the case along these 4 tasks of MI. So engaging, focusing, evoking, and planning. Kind of give me the structure for the case I'm going to share with you guys. So engaging, we've got a wonderful 35-year-old individual who presented to clinic. I can't remember if she had one visit to OB before starting care with us, or we connected at OB. It was really close time frame when I was going through her chart notes. I couldn't pull it apart, which happened first, chicken or the egg. At any rate, it may have even been within the same week. She established care with OB and us. She was about 20 weeks estimated gestational age at the time she presented to our clinic, reporting concerns about daily fentanyl use, which she was smoking, near daily methamphetamine use, which she was injecting, and then daily cannabis and nicotine use. She had had previous 4 pregnancies. 1 was a miscarriage. 2, she had delivered at term, and then the one she is currently carrying, that she's pregnant with. In the first pregnancy, she smoked cannabis. That was the only substance she was using at that time. She was probably about 19 or 20 years old with that pregnancy, because that child was about 14 when we were providing care to her. And she was able to stop using cannabis during that pregnancy. The second pregnancy that she delivered, that child at the time we were caring for her was 5 years old. And she had used multiple substances during that pregnancy. So now she presents with this pregnancy at 20 weeks with opioid, stimulant, and cannabis, as well as nicotine use, and wanting to make it a different outcome by engaging in treatment. So she wants to transition to buprenorphine. We had talked about options, ways that she could go about it. We maybe even discussed methadone at one point in time, trying to give the information so that the individual in front of us can make the decision for what is going to best serve them. She'd had experience using buprenorphine off the street when she couldn't get other opioids, just to keep from getting sick. So she had some familiarity with that and decided that was the route she wanted to go. And that she did want to initiate medication for her opioid use disorder. One of the things that we do when we start care with patients in our clinic is we want to get to know their story. We want to know what her hopes are. We want to know what their goals are. And it's over time. We don't try and do this all in one visit. We know it's going to take time over several visits. So really learning her story. And one of the questions that gets asked during that intake time is, tell me about one of the best times in your life. Like, what did that look like? What was going on? And it's always really illuminating when we learn what that is for someone, what the best time looked like for one of them. Not this case, but another case, one of my, it really shines a spotlight, super bright spotlight on how hard our patients' lives are sometimes. But one of my patients, when asked this question, she said, the best time in my life was when I lived in a group home. She was 13. No, for most people, that's not going to be the best time of your life. It's going to be one of the darkest times. But for her, it was a place where she felt heard. It's a place where she felt seen and cared for the first time in her life. So for this particular patient, though, it was her father's presence in her life. And I think she was an early teenager when he committed suicide, which that speaks volumes to maybe the environment she was growing up in, a father with mental health concerns. I also think he had a substance use disorder, but it sounds like he was at least a stabilizing presence in their lives. He was someone that she missed when he was no longer there. And then what happened following his passing, things got tough for her. So best time in her life was prior to her father's passing, her early childhood. So engaging with our patients, right? We want to know more about them. What are your hopes? What are your dreams? How do you want to go about achieving those hopes, dreams, goals? So obviously she's interested in medication for her opioid use disorder. So that requires her stopping the fentanyl and going through withdrawal. Mind you, she is 20 weeks pregnant. And the idea of someone withdrawing while they're pregnant makes a lot of us nervous, as it should, because there's concerns about things like pregnancy loss. We have literature, though, that shows us that that is not the concern we once thought it was. In honesty, when people are in active use of opioids, they go through periods of withdrawal, on, off, the whole time when you're chasing down that demon, trying to find your next source and ability to use opioids. quite often you're experiencing sickness. So, and this is a controlled environment, like we have the answer to, when you get this sick, you need to start the medication and it will go away. So she was given pretty clear directions on when to start the medication. There was a time when we would do this inpatient, and it typically would be age of viability on that we would do this in the hospital. Otherwise, we would do it outpatient. She kind of, because we didn't have her data, kind of teetering along those lines, but also in full transparency, our hospital didn't have any policies and procedures around doing inpatient inductions of pregnant women onto medication. So we kind of had to do it outpatient. But that's also the direction that this is all going in anyway, is it's all pretty much outpatient, even for our pregnant patients. So she was given directions on how to start the medication. She did appropriately get herself switched from fentanyl to the buprenorphine without any pain or discomfort associated with precipitated withdrawal. She did well with that transition and came back to clinic taking 8 milligrams a day. So not sick, not withdrawing anymore, but she still did have cravings. Notably, her daily meth use had decreased from daily to, or almost daily to just a few times a week. And she had also switched from IV to smoking. And that transition from IV to smoking was actually a result of a motivational interviewing moment with her medical provider at the time she was seeing, who happens to be a guest we have with us today on our Echo. The discussion that they had, actually in his note, he mentions utilize motivational interviewing to discuss transitioning from IV use of methamphetamine to smoking to reduce potential harm. And she had done that based on discussions that she'd had with her provider. She was also going routinely to her OB visits and receiving prenatal care. So high quality engagement, getting to know her, teaching her about what our services are, how we're here to support her, how we're here to guide her through the process. She's able to make some changes, getting OB care, doing the things, right? This is going great. It's fantastic. She is able to fully cease fentanyl during pregnancy. It does slow significantly her methamphetamine use, but it does not stop. So she does end up having a cord that tests positive for methamphetamine when the baby delivers, but it's negative for fentanyl. The cord will actually contain information for 3 months, like the 3 months prior to delivery. So she was able to fully, completely cease fentanyl use in that early second trimester of her pregnancy. So by the time she delivered at term, there was no more fentanyl flowing around in that lovely transit system between her and baby. Because of that meth positive cord result, DCS case is opened. To be honest with you, it could have been negative for meth, and because she was prescribed buprenorphine, there would have been a DCS case open anyway. But with the methamphetamine being present, and then also because of some concern she had about her daughters who were actually not part of a DCS case, but she had placed herself into her mother's care. So that her daughters are living with their maternal grandmother. She had some concerns about some family dynamics there, and she did not want the baby to go there. So they had an out of family placement for that child, because she felt that was the safest and best place for the child and not with her mother and stepfather. But because of that, she only gets 4 hours visitation per week initially. She needs to test negative, which she did in the hospital for methamphetamine, and then she needs to continue to have appropriate drug screens in order to continue to see baby and have visitation. But during this time, baby's delivered, baby's in a setting, she's got her plan, her care plan in place with how she can see the child and the stuff that she needs to do. She starts painting, working to build a crib for the baby because she's planning on bringing the baby home. She's working towards the goal of bringing baby home. The maybe, and then we found a maybe not boyfriend, well, father of the baby, boyfriend. He used fentanyl, used meth. We'd been around her. He lived in another town in another state, but close enough that there was still some contact. He had been using fentanyl, still using fentanyl around her. She had been working on boundaries. And all of these are things that had been pulled out from her experience between the case management and peer recovery specialist and counseling and medical engagement that she's receiving from us. That these are the things that she's experiencing and developing. strategies, plans, and ways for her to navigate the life that she lives, because that's the world that she's in and she can't completely avoid it. So even though he is around, she's done really well to avoid use, even where she's like, if you're going to do it, don't do it here in the house with me. Go away, come back. But she was making plans to watch fireworks with her family for the 4th of July weekend. Wants to come back to group, really interested in building, these are her words, building a positive social support. So engaging in broader community, engaging in supportive environments, engaging in things, because if she's with her family, she's with her daughters, they're doing something fun, non-substance related, enjoyment with her children and building memories and connections with them. So evoking, what is it that she's going for? What is it that she needs? What is it that is driving her? The full custody of baby, she's building a crib. Her desire to continue and maintain her sobriety. Her older children, she wants them in her care full time. She has concerns, and it's something that we navigated during her care with us. She was concerned about the stepfather molesting her 14-year-old daughter, if nothing else, putting her in situations that were inappropriate, such as showing her cartoons that were pornographic in nature. So we actually navigated and walked with her through the process of her putting in a DCS call because of concerns about the environment her children were in. And the ramifications and backfiring, some of the other things that happened during that time were all things that we helped walk her through. She also wanted meaningful work. It was part of her DCS case to have meaningful work, keep meaningful work. She had actually trained in culinary arts, and I think had a degree in that as well. And when we first started working with her, she was working in a restaurant, a fast food restaurant, but also she was working in the kitchen. But she ended up losing that job secondary to some pregnancy related stuff. And then plan, how are we going to go about doing the things that that she had set a goal for? What she needed to do is attend all DCS required programs, make certain she keeps all of her appointments, participate in groups, spending more time with her children, as this gave her joy. And that's definitely what we were looking for, ways for her to experience dopamine that did not include methamphetamine, because as you recall, during the pregnancy, she still used meth, but now in order for her to regain access to her child, methamphetamine had to go. So finding ways in which she could find joy in other ways that didn't include substances, and spending time with her 14 and 15-year-olds children was definitely a source of joy for her. One of the things she was doing, again, related to obviously something that was a passion for her, cooking. She was teaching the 14-year-old how to cook, and some of her favorite stories were to share that they had been doing together in the kitchen. And then limiting her exposure to people who were in her life who continued to use at one point in time, because she has just the sweetest, biggest heart. The father of her 5-year-old had gotten out of jail, and he and his girlfriend needed a place to stay. Probably know where the story's going. They all end up staying at her place because they don't have any place to go. And then there's the boyfriend who turns out to not be the father of the baby, which actually ultimately is what ends that relationship for the time being. They all end up crashing at her place, and they're all using, and they're all in her house. And she's just like, I don't know what to do about all these people in my house who are using. I think they've stolen my buprenorphine. So some of the what we see happening was happening to her, and putting a few dings on her plan. She did engage in a lot of sustained talk, but we were definitely seeing some of her intentions falling short of what she had intended, such as the people who are currently using, how to minimize her exposure to them, and having 3 people who are actively using substances in her house. With maybe some harmful behavior for her outcomes, her goals. But even that has a function. It's an opportunity to learn. It's an opportunity to see, like, oh yeah, this is why I don't want this happening in my life, because it pulls me down and it pulls me back. So I kind of glossed over, like I walked through, she was pregnant and these are the things we did, and she was able to stop fentanyl, and there was meth, but it was much less, and she used it in a far more positive, safer fashion than what she had been using, minimizing risk for infection and communicable diseases. But also we had issues like transportation and missing appointments and bridging medications, because it was the first time it had happened, connecting her to her next appointment. But there was something about that lack of contact, even though we bridged meds and she had access to medication, it was actually a whole nother 2 weeks from the missed appointment before she actually came back into clinic. So we had actually a loss of connection to medication and sustained exposure to the medicine that was keeping her from returning to use. And it wasn't fentanyl that she returned to use of, but she increased her use of methamphetamine. During the time that she was using methamphetamine, she picked up a shoplifting charge, so she had a new charge, which ended up in her spending time in the detention center. During her pregnancy, part of the missed appointments and missing medications and being out of the loop for a minute, she ended up admitted into the hospital with pyelonephritis. It's very easy to get urinary tract infections during pregnancy. It's a fairly common thing we see in pregnancy. And a common complication of that is pyelonephritis. So she was in the hospital with an infection of her kidneys during her pregnancy. Oh, I misspelled hospital there. I'm a little wild with my O's. Also during the pregnancy, she went in with elevated blood pressures. She was also losing protein in her urine, which is possibly an indication that she was dealing with some preeclampsia, which is a pretty serious complication of pregnancy. The protein in the urine definitely leans you more in that direction, but the elevated blood pressure also, we were all like, could this be the methamphetamine use that's playing a part in elevating her blood pressure? Also, during her pregnancy, her brother dies of an overdose. She's facing possible jail time, which she does end up having to complete after delivery. She has court for the charges for shoplifting and DCS coming up. Baby's in a foster situation, which is not what she was hoping was going to have happen, but the methamphetamine that was not able to fully go out of the picture was positive at the time of delivery. She was frustrated. She was frustrated with the limited amount of time she got with the baby. Once she has the baby, she is able to fully cease meth use. But a lot of that is because of the open DCS case and knowing that in order, it's interesting, the dial flipped a little bit. Abstaining from methamphetamine during the pregnancy was very challenging for her. She did significantly reduce her dose of methamphetamine, how frequently she was using it, but she was not able to fully stop. Once baby was delivered, however, she was able to stop and she was initially meeting all the requirements of the DCS case. But 2 months following delivery, she had spent her time in, I think the prison, can't remember, not prison, if the jail had happened yet, but 2 months after she did have return of fentanyl use. She was experiencing low mood, largely because of the time she was not getting to spend with the baby, grieving her brother's overdose that had happened during the pregnancy. She was not in a good place. She and the father of the baby had been fighting, except for he wasn't the father of the baby. The guy she thought was the father of the baby, he wasn't the father of the baby. They had been fighting. He was supposed to be going to prison, but he kept running. So she was at one point in time harboring a fugitive, which was also stressful. So low mood impacted her cravings. She returned to use of fentanyl. She re-engaged with us. She started to attend SMART, one of our peer groups that we have. She was having increased cravings for methamphetamine because of the low mood. Just kind of trying to tie her back in, getting her connected to care, restarting some of the places where we lost a little bit of momentum. Definitely depression with anxiety. Again, she's postpartum, so knowing that she had some depression, anxiety pre-pregnancy, she's at higher risk for postpartum depression. So checking labs, her PHQ-9, GAD-7. We talked about starting medication, discussed what to expect from that, and she did want to start an SSRI on that visit. So again, about 8 weeks after delivery of baby, and she's finding it challenging, and is having some less than beautiful moments in this new world she's found herself in. One of the visits, she comes in and shares that she feels as though she's failing in all aspects of her life, and she does not want to fail here with us. Part of that discussion where she felt she was failing everywhere was she disclosed to us that 3 weeks prior to her visit, she had actually attempted a fatal overdose with fentanyl. she had Narcan in the home and she hid it so nobody could find it. She very clearly attempted, pulled herself an injection up with enough fentanyl she felt that could do it. And she blacked out. And she remembered waking up. Basically, someone had taken her to the ER and she refused to get out of the car. She woke up at that point in time and refused to get out of the car. So contracted her for safety, started the SSRI. Time moves, she feels as though the SSRI is helping, her mood is lifting a little bit, she does get a job. She again stops use of methamphetamine and fentanyl. Then she has her court date. That was early September, mid-September when we met with her. And then I think the court date was up in October. So we've had several weeks of kind of restabilizing from that return to use episode. Court decides that she needs to go in for 60 days. So she comes back to us knowing that we've got her reestablished on buprenorphine, but she's gonna have to go into jail. So question is, do we want to try and connect her to an extended release injection of buprenorphine? Does she want to detox in jail? Do we want to try and wean her, do a quick wean off of the buprenorphine before she goes in? So talk through what are your options, what do you want to do? So motivational interviewing is clearly used here, like this is the situation, how do you want to handle it, and helping her make decisions that felt right for her. And her decision was, she felt that she's a very insightful individual. With the recent fentanyl use that she had, she was safer staying on the buprenorphine and not trying to taper off before she went in, because she was fearful that she would use an overdose. So again, really good insight. Recognizing that her risk for overdose is high, should she be without the buprenorphine. So not tapering, doesn't want to do the sublocade, and she plans to withdraw in jail. So, planning ahead, if you withdraw in jail, as soon as you come out, you come here and we can get you on naltrexone, if that would be of interest of you, because she had expressed desire to maybe not always be on buprenorphine. That was appealing to her, that idea. So we had made the plan at that point in time, and continued with that until she was incarcerated, that as soon as she was released, she would connect to us, get an appointment in clinic. Our ability to talk with the detention center, and it was not our local county, but another county. And those lines of communication are strained, they're challenged. So us knowing when she was getting out, she was just gonna have to call us and tell us she was out. Because there was the potential she would get out a little earlier than 60 days. So we weren't quite certain what to plan for. Let's put an appointment in for 45 days. Let's put an appointment in for 61 days, from our last meeting. So really driving home, as soon as you're out, call us. So the next time we saw her was early December, and she'd been released from jail a few weeks at that point in time. And about a week after being released, she had returned to use of methamphetamine. And then just a few days before her visit with us, she had returned to use of fentanyl. So the plan didn't happen the way we had hoped it would, but the important thing is that she did come back. We did not completely lose her to follow up at this point in time. As we had talked about the Vivitrol, she had only the one use of fentanyl. We were not going to restart the buprenorphine. She did not want to at that time. She wanted to do the Vivitrol, the long-acting injectable naltrexone. So we sent the script. She was going to pick it up and bring it. But she left it at her house at that particular visit. So we planned her next visit, short follow-up, and she was going to bring it at that next visit. Very clearly does not want to go back on buprenorphine, but wants something to keep her safe. And she's got the Vivitrol at home. She's going to bring it to our clinic. I'm like, bring it back today. Bring it back tomorrow. If nothing else, bring it back at your next appointment. But anytime between now and the next appointment, just show back up with that injection and we'll do it. So our last visit with her was December 20th, but that was the plan. Come back anytime between now. We're getting into the holiday season, right? So there were some clinic closed days, but just come back. Ooh, I'm just trying to my water. Just come back. We'll give you the shot. If nothing else, on the 27th of December was her follow-up appointment. We will give you the injection at that time. No show for her 27th of December appointment. She calls to reschedule. January 18th is what we had available at that time. Post holiday, our schedules were booked. She selects January 18th. And she's a no-show for that visit as well. Um, I do think probably a year later, somebody did hear from her. She may have moved over to the town in the state where the boyfriend that she had had was living. She may have gone back over there, and they do have a fair number of support programs. And I think she was trying to get tied into something there. So, I mean, I kind of left this as a cliffhanger, like we never heard from her again. Um, that's kind of a horrible, scary cliff to leave you hanging on. We did hear from her. I don't know if she ever really re-engaged with treatment or not. I hope that she did. But it sounded as though she had moved over to a neighboring state. And it's been maybe by talking about it and thinking about it as much, I'll be conjuring her back up and maybe we'll be hearing from her soon and we'll reach out to her. But, it's been a couple of years since we last had any contact with her. But, many times people look at pregnancy as a highly motivated time for an individual. And it is, there's a lot of motivation, like something's gotta change. I gotta do something different. It's not uncommon for people to be the first time they engage in treatment is during a pregnancy. However, I find it to be very challenging because there are all kinds of wonderful and like, I'm gonna do this. I have all the reason to do this, but it's almost as though the motivation comes up, and so does the guilt. And guilt often feeds cravings, return to use. You use, you feel bad, you've got the motivation to not use. It's the cycle sometimes that our pregnant patients will get into, where there's a lot of maternal guilt, a lot of blaming yourself for everything. Everything I do is wrong. There's nothing I can do that's right. What's the point? And you use, and you're like, oh my God, why did I use? And it can be a very challenging time. It can be very exciting. It can be a very amazing things can happen during this time, but it can also be very challenging, very emotionally taxing, it's a very vulnerable state to be in being pregnant. And you add something like this on top of it, and the judgment people are going to throw your way. It's hard. It's really, really hard. So when you're engaging in change and you put on a lot of these factors, it's not always going to be a sustained success, but having success at all is success. Whether they maintain it for a month, a day, a year, it doesn't matter. She did experience change. She was able to maintain it. She has that learned experience of success. And so the potential for her to go back and experience success again is present, and I think that increases her ability to have success in the future. So we don't have a pretty bow on the end of the story, because that's just sometimes how it works. And that's my thing.
Thank you. Does anybody have any clarifying questions for Dr. Troxler before we go into a full-blown discussion? There's a lot to discuss, but does anyone have any clarifying questions about the case first? Go ahead.
Joyce, it's been a while and you may not recall, but when she attempted her overdose, did she have any buprenorphine on board? I'm wondering if perhaps buprenorphine may have saved her.
Yeah, she would have. It is like timing, like when exactly that happened. Had she had some missed appointments, was it, had she been a kind of one of those like little breaches in care where it had been maybe a few weeks since we last saw her, but she was also quite capable of finding buprenorphine on the street if she needed it, if she had had missed appointments with us. But again, she was taking a higher dose. At one point, she was on 20 milligrams of buprenorphine. I can't remember if that was towards the end of pregnancy. In the notes, I can read where like we've come back down to a lower maintenance dose. It's not uncommon that will increase, especially in the third trimester of pregnancy, the buprenorphine dose. And so she was on 16 around the time that she had had that attempted overdose with the fentanyl. So it is quite possible that it was the buprenorphine that kept her from going all the way, because she was like, I pulled up more than enough to do the job. Good question, Jack.
Yeah, any other clarifying questions? Okay, well, let's move into discussion. There's a lot to talk with about this case. It's a long case and it's a great one. So who has comments, questions, or thoughts about perhaps MI and how we could have used it in this situation?
I was curious if she ever came to SMART. I guess that was more of a clarifying question, but do you know if she ever ended up coming or going on like a home visit with the CPRS or any of that kind of engagement?
She did come to SMART. She did attend SMART. She was a regular attendee in SMART. Actually, because you're in my clinic, Amber, I will show you the artwork that she left to hang in the SMART room. So she was definitely a participant. She was a creative individual, so she also engaged in our art therapy group when we were having that one. She was able to participate in that. She really enjoyed the groups, and she did also get to benefit from home visits with our CPRS. So yes.
Thank you.
Other questions, comments? I have multiple myself. The first is just the tremendous social determinants of health in this case. I mean, it's amazing, right? You know, the amount of things that she was going through this, and just one thing after the other, from from custody issues to incarceration to even like paternity, issues. It was just, just astounding at how that can contribute. So that was good to know. I'm going to guess at some point somebody discussed with her residential treatment during this. And obviously that's something that would have probably been good for her during this. But how did that discussion go?
As it goes often when you bring it up, level of care indicated we need to go to a higher level. She did not want to leave her daughters, so she did not have custody of them. It wasn't an official arrangement, but she lived in a trailer that was like, in my mind, the way I pictured it, it was like they were on a hill. Her mother with her children were up here and her trailer was down here. Like literally they would walk back and forth. Like you'd go out her back door and yell up to them on like the porch. Right. And so that contact that she had with her children, she was really involved in their lives. They would talk to her, like they had a good relationship, she and her other children. And then the concerns that she had, and I kind of touched on it a little bit. It was really gross and concerning, and ended up in the end, nothing really came of it. Nothing changed with, because she was at a really stable point where she was actually able to like pick up on the cues and be like, hey, wait a minute, talk to me a little bit more about whatever this, however they referred to this guy. For her concerns from her report, he had been watching pornographic cartoons with the 14-year-old. And she was engaging in behaviors that were concerning, like really wanting to dress in certain ways because it made the step grandfather, it made him happy. It pleased him to see her wearing lipstick and stuff like that. So it was very concerning, and she did not want to be away. She wanted to be like, make certain that she was there as a place that daughter could come to and get out of that house if she felt like she needed to. The DCS call, like, they didn't do anything. They didn't do anything.
Okay. Yeah, very challenging. But yeah, I've run into that situation
Not an option.
before where childcare is a responsibility that people can't leave to go do something like residential, which maybe. And I guess this could be part of our motivational interviewing with her. If that would be our goal with our motivational interviewing, would be get her to some higher level of care. But that getting her to realize or verbalize that, what's in the children's best interest may also be what's in her best interest, and getting her healthy may be a big component to them being healthy as well. Because, I know she thinks she's taking care of them, but while she's using drugs, she's probably not, right? Or at least she's not doing her best that she could be doing for them. So, I think part of that is getting her to verbalize that as part of motivating her to go to treatment.
She did attend IOP, so she did kind of get a little bit higher
That's
level
good. Yeah.
as a result of the DCS requirement. She was attending IOP. This was also, because this case has got a little bit of age on it. It was also during the fallout years from the pandemic. And so she was not getting to do in person with her IOP. It was via Zoom. So
Mhm.
But one of the things that she really liked about it, and which kind of gave her positive regard for her group, that they felt for her, because she would be cooking, because it was a morning IOP, so she'd be cooking herself breakfast and be on the camera doing all this stuff, and they're all like, "Oh my God, when do we get together? And can you make us breakfast when we get together?" So she did have some community, but again, as all of us experienced with that pandemic, it wasn't the same. Like we are in this little Zoom room. Like luckily, in a minute, I get to be on the other side of the wall and I can say hi to Jack in person. But during the time that she was receiving her care, was definitely this is the only way we get to interact with most people.
Just want to clarify something. You mentioned something about the contract for safety after that attempt. What actually happened in the cases that they do have, because the research shows that the people that they do the contract for safety, which is a shaking hand that I'm not going to kill myself again, that doesn't work. But what we do in a clinic, which you are aware of, we do the safety plan. Safety plan is a little bit more detailed that would cover any kind of the situation that the patient has a high risk for suicide, which she certainly had. She was a user of the substance. She had a previous attempt. She had a family member, close family member, who died of the suicide with the very bad social support that she was going through all of the stressful situation. So she would be in a high risk level that require frequent visitation, which we did provide that frequent ability of the coming for at least weekly. If it wasn't the case to be referred to the inpatient service, it can do the weekly, visit. And that safety plan, which is a series of the question, which most likely you guys are aware of, and that about the different situation, what would be the action that needs to be taken. And the patient can have the copy of that safety plan in hand, and that goes through it every day and looking at the opportunity, if the call to the friends, call to the provider, going for some exercise or doing something that the patient herself or himself would indicate that would reduce their stress level. So that I just want to clarify that the contract for safety is not just shake a hand. It's a safety plan needs to be in place.
Yeah, I think it's just holdover language because they did go through, because it was our behavioral health team that discussed with her, the if then and these are resources and how to reach out and all that type of thing.
Go ahead, Jack.
Joyce, I just have this image of being invaded by her boyfriends that are all using and how risky that would be for her. I understand she wasn't interested in residential treatment, but are there any recovery residences like Oxford House in this area that would take somebody on buprenorphine? I know in the past that's being on buprenorphine was an obstacle.
There are more rooms, more houses. The majority, I think, still are medication free, like but there are ones that do, and that is a definite change within the last couple of years, Jack.
Yeah, Oxford, at least locally, will do it.
And I don't think it's every house, but they do have some.
Yeah, most of them. I certainly have patients there.
But that's been a nice change. But at that time, no, when this case happened, that wouldn't have been an option. The other thing too is where she was wanting to regain custody, that would have been challenging for her because none of them accept children. She would have to have gone west of here for that to have been an option.
It would also have separated her from her children in the neighboring trailer.
I think you touched on a good a springboard too for some motivational interviewing with the best time in your life question too, about probing what it was about that time that made her, her life so good then. and what we could use now, or what we could do now to make her life more similar to the way it was back then. And that could probably involve some changes, regarding substance use. So I think that would be a good avenue to explore with her. I like that question.
A good question. The other patient that I alluded to, the best time in her life being when she lived in a group home. I've actually utilized it a number of times when we've been in a challenging spot, or we've been trying to regain some footing, or just to, she's in a situation right now where the person who is her mother, she still lives with, and I'm like, she has trouble with her. They go through these cycles all the time, and she just gets disappointed and let down over and over and over again. I'm like, you do remember what you told us the first time we met, and that the first time, like the best time in your life, was when you lived in a group home. You're trying to live in a home with the same person that couldn't parent you when you were 13. And that hasn't changed. So let's find a new home. But I mean, because it is, her home is part of the reason why she's experiencing what she's experiencing, because every day she's in that house, it's a trigger. Because she's with the person that couldn't parent her, who still can't be a parent to her, even though she's an adult. So yeah, that is an excellent question, and it really helps us frame a lot of what our patients are facing and experiencing, and tying it back to, we do have a best time. What did that look like? How do we go about re-achieving that? What would it take?
I'm also curious about, I might be a little unclear on the timeline, but when the boyfriend and his partner moved back in and they're kind of all using around her and stuff, did she have some insight into the fact that this, might not be the best option for her? And I guess I'm also curious if they were still living with her by the time that we lost contact with her, or if she got them out of there.
He did get them out of there, and it was coming from a place, because again, as I mentioned, she has just this big loving heart, with some, some scars and hard patches on it because of some of the things she's experienced. But she was in a place where she was doing really well. He had just gotten out of jail, and she was like, I believe in you. I want to show you my support. You're the father of my child, my second child. And you need a place to kind of gather yourself together before you go on to the next thing. So when he came in, I think there was anticipation of, he was in a better place and he was ready to do some change himself. And she wanted to give him, because she had experienced change and she knew how great it was, and she wanted to give him a safe space in order to launch himself from. And then it turned into something else. And then I think it took to the point where she was like, and they're stealing my buprenorphine. I had to get them out, because she saw that not only was their use around her triggering, but now the thing that she had to keep herself stable, they'd taken, and she didn't have that anymore. So they had to go. So she was able to get them out. And that was one thing, when she set her mind to like, this is what's happening, that is what happened. She was definitely one of the great things about her personality. When she made up her mind how something was going to go, she did not falter. She was not shy about it. She did not have any qualms. She was like, if I upset you, I piss you off, I have to punch you in the face. I don't care. I can do all of that. And she would, and she maybe did a few times, but none of us. So we were all good.
All right, we have a couple minutes left. Any further comments before we close things out? Okay, well, if that's all we got, then that's all we got. We'll give you 5 minutes back of your day. Melissa, would you remind us as far as what's next?
Yes, our next one is going to be, we will not come back together until February the 5th. And then we'll have two sessions every month as well. So we'll have February, March, and April then, with 2 sessions a month, I believe.
Okay, great. So look out for that. We should be sending out an email with the dates of those, and the content too. But it's been a great session, and I hope everybody's enjoyed it.
Thank you, everybody. Happy New Year, and all the
Happy New Year.
now when we see you again.